the spotlight. In the spotlight.
Hi, my name is George Greene, and I'm President and CEO of the Hospital Association of Southern California. Welcome to In the Spotlight, where we shine a spotlight on hospital leaders across the HASC region, which is comprised of the 6 largest counties in the greater Los Angeles area. Today, I'm with John Chapman, President and CEO of San Antonio Regional Hospital. John has continued the mission of San Antonio by delivering high-quality care to the patients and communities that they serve. John, welcome to In the Spotlight.
Thanks, George. Thanks for inviting me.
Always a pleasure to be with you, talk with you, and, of course, learn from you. If you're okay, I'm just going to jump right into some questions that we have for you today, John.
That'll work fine.
All right, perfect. Let's get into it. So my first question, I'd like for you to share a little bit about yourself, your journey in healthcare, and tell us a little bit about your background and what brought you to this position, and maybe even a little bit about what excites you about being the leader at San Antonio Regional.
Yeah, I'll tell you, when I got out of college, I never thought I'd be here. I went out of college, and I was one of those pre-med students coming out of UC Berkeley. And like my daughter now, figured out I don't want to do 7 years of medical student and medical education. So ended up becoming a microbiologist, of all things. With that degree, I started working at the University of California, San Francisco. A few years later, managed their micro department. They paid for my MBA, ended up running their entire lab. Things were going well. God was good. Ended up running service lines for UCSF. And then one of the chairs, the one who paid for my MBA, says, stop being fearful. Get out of the same place for this long a time. Go across the bay with me to Highland Hospital in Oakland and become their COO. So that's what I did.
Wow.
Did well there. It was nice to show people in Alameda County that a hospital could be profitable. Was recognized by a few headhunters and found my way down south here to San Antonio Regional Hospital. And it couldn't be, for me, it couldn't be a better match. What drives me is, and I think it's true when you talk about nursing or any other profession, in healthcare, that's the only place where you can actually feel you made a difference for somebody. And hearing the patient stories coming out of our units and seeing how a leader of a hospital can make a difference for their community. So my goal, when it's time to retire or leave, is I can look back and have metrics that show the community's improved in terms of their health.
Well, it's really been an honor to work with you, and we are so glad that you made the migration down south, and you're now in the HASC region. I would be remiss if I didn't say you're actually our future board chair. And although it's been a pleasure working with you as a board member and an executive committee member, I'm so looking forward to working with you as our board chair.
It goes both ways. You're a blessing to the Southern California community, too, in your role.
Well, appreciate it, John. Appreciate it. So you have led San Antonio during a time of tremendous change, and that takes leadership. So why don't you talk a little bit about your leadership style?
Sure. It's funny, when they offered the job to me, I remember the chair at 9 o'clock p.m. calling me and saying, hey, we're at a board meeting. We're offering you the job. We want to stay independent. We had $24 million losses for the last 3 years. I'm like, well, we can only go up. So I enjoyed the challenge. I've done turnarounds over time at a number of places. So my leadership style is transparency, communication, really trying to make it as much of a family as you can in a hospital. I know family is a word that people sometimes shy away from, but if you know San Antonio and you think of an independent hospital, it is. And I'll give you an example. My first day there, they're giving me a tour at San Antonio. The previous respiratory therapist director introduced me to his wife, then his son, and to top it off, about 10 minutes later, his ex-wife.
Oh, wow.
I know. I hope he sees this podcast. And it just shows that the community and San Antonio are just intertwined. And it continues to be, and it continues to grow.
Speaking of San Antonio being part of the community, those community roots are deep. But as I mentioned before, we are going through a tremendous time of change where you have to meet the challenges ahead of you, and a lot of times that involves change. So how do you take that challenge, these challenges head on? How do you lead change while still honoring those deep roots in the community?
That's a deep question, but it's a valuable lesson that I learned is you have to do what's best for your community, patient first. Now the trick to all this and what works for me is how can I get a win-win out of things? Can I put in a program that perhaps loses money? However, it brings in additional volume, additional community members who may be having to use a stronger service line, one that's more financially productive. And at the end of the day, how do you measure that? How do you educate the community of what the hospital should mean to them? So many people know about care at a hospital. They know about how long it takes in an emergency room. But do they really know about our morbidity statistics, our mortality statistics, why they should get care there for the diagnosis they may have? And, just like this podcast, having a social media presence was probably number 2 on my list besides turning the financials around. And I think both we've done a great job, my team and I.
That's great. That's great. And, your nod to technology and what's needed in order to advance your mission has to be noted by your leadership team, your board, anyone who comes into your hospital. You mentioned your community. Speaking of that community, what are some of the biggest public health needs in the community that San Antonio Regional serves?
There are a ton, but first and foremost is the lack of primary care in the community. And how does that play out? Where do you see that? You just look at ED visits. I've shared this statistic with you probably too many times, but it still holds true. It still holds water. The average number of patients per year touching an ED bed is about 880 statewide. In San Bernardino County, it's approaching 2,000. So double the amount of people going to an ED. It's kind of embarrassing for us to say we have the 3rd best time in all of San Bernardino, Riverside, and Orange County for our ER throughput times when people are still waiting over 3 hours.
Right.
So we don't say that on social media, but we do tell them the outcomes, the care, and we've put in a number of innovative solutions. Not as a tangent, but I do want to tell you this when we're talking about taking care of our community. In the ED, we actually put a physician at registration and triage. So we know people might have a wait to get back into an ED bed, but we have a physician already checking you out in the first 15 minutes.
Wow.
Doing your lab tests, sending you to imaging, and the community sees that. But you really have to educate, right? We talk a lot about educating politicians. We also educate the community of what we do, what we go through, our quality. I'm a big believer you can't manage what you don't measure, and you definitely have to broadcast those measurements.
Definitely. Well, I want to talk a little bit about activities outside of the walls of your institution. So social determinants of health play such a role in public health, in personal health, and really the way in today's world you have to operationalize hospitals. So what is San Antonio Regional doing in the community that's more upstream to try and take on some of those social determinants of health?
Sure. We've heard of pull versus push systems. We noticed after COVID, and I think your audience has probably noticed too, that many individuals put off their healthcare needs because of fear around COVID at the time. Well, they got used to having 2.5 years of not seeing their providers, and now they're finding out there's more severe diagnoses that they're taking care of now, right? But many people still ignore it. So how do we get out and do what I call a pull? instead of them coming to the ED, that's the push, how do we go out into the community and meet their needs there? And that's where it really is useful to have what's called a community health needs assessment. So by zip code, George, we look at what the top 3 or 4 diagnoses are. And then we find a way to get to events out there and meet the community member where they live. So as an example, I'll use 2. 2 months ago, we were in the Catholic churches after Spanish masses, and we brought physicians. We brought the actual hemoglobin A1C tests. I'm a geek, remember? I'm a lab person.
Right.
That's the easy way to measure if you're pre-diabetic or diabetic. We brought a cardiologist who actually listened to people's hearts, had EKG there, and we were very proud that we diagnosed 25 community members who had full-blown diabetes and didn't know it.
Wow.
And then, of course, this was all free, by the way, and then what we do is we do wraparound services. We brought them into our Care for You clinics, which is our primary care clinics that we started, and I'd love to talk about that as a secondary piece to this story. So, going out to the community, in Fontana, we went to the Baptist churches. We had more of an African-American community, and we all know what is an aggressive form of cancer in young African-American men or middle-aged. That's prostate cancer. We diagnosed 7 cases with prostate cancer that they didn't know they had. So we continue to do this. We call this our population health department, right?
Love it.
On top of it, where do we get the people to go out? Well, we said, remember primary care, we didn't have enough? So we started our own medical group, started our own primary care practices. Now this next question your audience should have is, where are you getting the physicians if they're not there now? We started our first residency program ever, ACGME credited, for internal medicine and primary care. We graduate 20 physicians a year. My goal is to keep most of them and continue to satellite dozens of these family medicine practices throughout the Inland Empire.
Wow. Great goal. And I wish you luck on that, because it's going to make a positive impact on the patients and communities that you're serving.
Absolutely.
One of the things you mentioned, community health needs assessments. Listen, I'm going to give you a little vignette here. As you know, prior to being the leader here at HASC, I was the association CEO for the Healthcare Association of Hawaii for almost 8 years. And one of the things I got the hospitals in Hawaii to do was to take those community health needs assessments and then do exactly what you described, identify the top 2 to 3 public health issues on each island, and then dedicate collaborative resources to trying to improve those 3 public health issues every 5 years, using data, using metrics. It was a phenomenal example of collaboration. It was a great story to go out and tell public health officials, elected officials, the community, and it raised and elevated the profile of the great work that our hospitals in Hawaii were doing. I actually am having very early conversations with the team at HASC about, are there hospital CEOs in the 6 counties who we think could get together and do something similar. So stay tuned, John.
Good.
I may want to recruit you. I'm in. All right. Next, I want to talk a little bit about workforce. Workforce has always been a challenge in the healthcare industry. And obviously, things like the pandemic, things like declining reimbursement, things like federal funding, state funding, even county funding being pulled back are going to further impact our workforce. What's San Antonio Regional doing to take that head on? You mentioned the fact that you're trying to get more physicians in the pipeline, but what about other skill sets?
Well, let me start with, to be able to tackle this, you have to be operationally profitable. And that's becoming harder and harder. Remember that 24 million gap I told you about?
Yeah.
Well, in 14 months, we turned that around, and we've had Moody's upgrades for the last 8 years.
Oh, kudos to you.
And that's in the face of rising inflation, but we've been what I call lucky and good, right? Part of that is workforce, right? To be able to pay and keep up with what I'll call the Joneses in LA or San Francisco. What we've ended up doing is created over 12 different workforce pipelines in San Bernardino and Riverside County. And it helps the community too. You may know that the average wage or standard of living in San Bernardino is fairly low. So what we're seeing is our top students who are going to top colleges and universities in San Bernardino are actually leaving after they graduate.
Right.
So why wait? We bring them in during high school. We offer them jobs before they graduate based on their degree. If you get this degree, we will hire you. And we tell them before they graduate.
That's powerful.
Right? So right now we have the lowest on your HASC data in terms of people leaving San Antonio. We have the best retention numbers in San Bernardino County. And the schools love us. So as an example of something we do that others don't, but very useful, you know, I don't know about you, in my day it was, okay, they want to go to college, I need some type of paper from a physician saying I'm interested in medical care. I've worked with you for 6 months, and they put them at a desk and do research. We bring students in San Antonio. The first day they're seeing an open heart surgery.
Wow.
We are putting them in our ORs. We are putting them in our cath labs where they're seeing how interventional cardiology is done. They're seeing dozens of surgeries. And why don't others do that? You know, sometimes they're afraid of risk or liability.
Sure.
It's not much. And these students really get a feel for, is this what they want to do?
Yeah.
And I'll tell you, for the college students that we've have gone through this program, we have 12 now working at San Antonio while they're going to postgraduate school.
Wow. Well,
Right?
That's a fantastic strategy. And I think you better be careful, because if this podcast becomes popular, other people are going to steal your strategy, John.
No, you know what? I'm okay with that in San Bernardino because we need more. In fact, George, the Board of Supervisors gave us a $225,000 grant to help train other hospitals on how to do it.
That's fantastic. That's fantastic. I mean, that's the sort of collaboration that we need. It's the sort of collaboration that we especially are going to need with all the challenges that I alluded to earlier. You've heard me say it before. We need more communication. We need more collaboration, because without it, it's not the fact that the industry is going to suffer. It's the patients and the communities that we take care of who will suffer. So I applaud you for that sort of collaboration, that sort of leadership. Along the lines of leadership, you know, culture is so important within an organization. And there are things that can be culture killers, and there are things that can be culture builders. With the journey that you've shared so far, obviously you have built culture at San Antonio Regional. Talk a little bit about what you and your leadership have done to build your culture.
I'd like to say I built it, but I was lucky enough to come into a family-style culture to begin with. It's just that operationally it wasn't happening there. So the challenge was to keep that culture, expand on it, and give them pride of, hey, we're one of the top hospitals in the region. And we do that through what I really call a culture of transparency. I'll say this out loud. It'll probably come back to get me in the foot later, but we're one of those hospitals. We have no unions. Now, I say that, George, and I've told you this story. My dad was a union leader for 30 years.
Right.
And I'm not bashing unions. There's many hospitals, many places that need it. But if you have a transparent culture and your staff believe that any issue they have, any equipment they have, any needs they have will be addressed by their leadership and quickly, not needed.
True.
And that's what's happening. That's what's happened at San Antonio. So we use a number of avenues to reach our 3,000 employees, whether it be rounding, which everybody says rounding, right? But what we do is we round out a dashboard. Every staff member could put on, it's called a stoplight report, what they want. And their manager or leader has to put down, yes, we did it in green. we're going to do in yellow, here's the weight, or red, here's not why it's not going to work. So everybody feels that they contributed.
I like that.
Guess where we start rounding the executives? We start at the dashboard. And we have the leader there and their staff.
I like
and they better have it answered.
Yeah.
Right?
No, that's fantastic.
Besides a number of events, one of my favorite here is the President's Luncheon. It gets a little fun at times because we'll take any question, submit it anonymously, and answer it in front of representatives from each department. We probably have 150 people there.
Yeah.
Some are pretty funny, from like, I don't like the peanut butter, to others saying, hey, I'm not being paid enough. And we're transparent.
Yeah.
We actually use HASC data, and many hospitals play poker and keep those salaries to themselves. We share with them. This is what San Gabriel counties, this is what San Bernardino, Riverside, and then they get an understanding.
That's awesome. That's awesome. And thanks for the plug. I have to give a nod to Terry Hollingsworth and her team, who lead the compensation and benefit analysis services for us, and they do a fantastic job.
Right.
And really appreciate you and others utilizing it.
So I'll say our staff's very educated and very in tune or what the hospital's successes and challenges are.
That's great.
Let me give you one example because I'm on a roll on examples.
Go for it.
Staff. We all have been staff at other places, whether earlier in our career or in other industries. Not only the Stoplight Report or the President's Luncheon, we have individuals coming up to us and saying, we can save money this way. And I'll give you an example that I love. Crash carts. The items in a crash cart probably total over $200,000 with drugs and everything else. Those who don't work in the hospital industry may not know this, but every time there's a code blue, if you open that crash cart, you use what you use, and everything else has to get dumped because you have breached sterility, right? So one of the nurses decided, hey, 70% of the time, all we need is an airway device. So why don't we just put something on top of the crash cart, a separate lockbox, just for airway devices? Saved us $2.5 million per year. Wow. I mean, the best ideas come from staff.
True.
That's why we keep them engaged.
Yeah, that's great. That's great. They're on the front lines, and they see the practicality or the impracticality of the protocols that are in use every day. So listening to them is really, really important.
Absolutely.
Really, really important. So health technology plays such a large role in healthcare, and it's something that hospitals and healthcare providers have to invest in today's world in order to advance their ability to take care of patients and communities. What are some of the latest technologies that San Antonio Regional is invested in?
Sure. I think we definitely see that primarily in our surgical suites. Think of old school replacing a hip or a knee or a shoulder. It's a subjective feel on angle and everything. We actually use Mako robots that actually tell them exactly what the optimal angle is per patient. It's almost like a physician playing with a joystick with robotics, and you get the best outcomes that way.
That's great.
Now, we talk about individuals going to ambulatory surgery centers. You're right. They can't afford $1 million robots. Am I getting reimbursement for that $1 million robot? No. But what I'm doing is I'm getting great outcomes, less readmissions, less mistakes, and physicians want to go to a place where there's less liability. Bring in robotics. People forget the indirect revenue or indirect benefit of investing in this. I have 2 Da Vinci robots for general surgery, 2 Mako robots, and just recently we brought in ion bronchoscopy. Not too many places have that. Ion bronchoscopy is the old days where they find an incidental node in your lung, for instance. Old days, they said, well, 70% of the time it's nothing, 30% of the time we'll watch it for 6 months.
Right.
And you end up watching it for 5 years, and we don't want that. Ion bronchoscopy allows them to sample and biopsy that 3 millimeters or less. No more 6-month waits.
That's incredible.
That's a new technology. In fact, it's so new, reimbursement is still being decided upon. But we decided to bring it in because we want the best for our community.
Well, thank you for sharing. And we may have to speak offline because this hip's starting to get really bad on me, John. I want to go someplace good, and now I know where to go.
You got it.
So, listen, healthcare's changing. Some of that change is necessary. Some of it's, frankly, being forced upon us. New reimbursement models, changes in funding. So when you look at the future of providing health care to your community, are you looking at more outpatient services? What sorts of models are you looking at that you think you're going to have to implement or integrate into your current way of taking care of the patients in your community?
Great question. When we talk about value-based care or value-based purchasing, if you look at the models out there or those being suggested by Medicare, for instance, perhaps some of the managed care plans are trying to get into this mode too. It's continuum of care, George, right? So what does that mean? I'm trying to explain that to your audience. Right now, if you go into a hospital and you get acute care for that episode, they reimburse either by a diagnosis saying, okay, average 5 days, this is what it should cost you with some profit, this is what we're going to pay you. In value-based care, what they're doing now is saying, not only are we looking at the days in your hospital, now we're looking at the days in skilled nursing facility. And we're like, but it's a different company. Doesn't matter.
Nope.
So how are you going to collaborate? How are you going to watch it? How are you going to keep the cost down? That's a risk. That's a risk to both organizations, and it's difficult. And now, think of expanding it past that. Now they're going to say, how are you preventing illness? Because we're going to pay you a PM per member per payment per member per month for you to keep people out of the hospital. So now they're using AI saying, here's where we believe that 20% of our insurance population is at high risk. What are you going to do to prevent them from actually going to your hospital? Right. We'll pay you for that. If they do go and it's a long wait or a short stay, they pay less. Right. So hospitals are taking on more risk, and they need to be a continuum of care type of hospital, either having the partnership with upstream primary care physicians and downstream skilled nursing facilities and home health, or do it themselves. And I think at San Antonio, as you can see with our primary care plan, we're taking care of the front end, the acute, and we're looking and partnering. And I think HASC is helping with that, with SNF partners based on outcomes and length of stay to find the best skilled nursing facilities to partner with value-based care.
Well, I think you're spot on. And hearkening back to my days of being the CEO of the Healthcare Association in Hawaii, note I say Healthcare Association because we represented the continuum of care. We represented skilled nursing facilities, hospitals, home health, hospice, even durable medical equipment providers.
Sounds familiar.
And when I took that position, I had hospital CEOs saying, maybe we should kick the post-acute care out of membership and we should focus on hospitals. And it was right around the time that the Affordable Care Act was being debated. And as you know, just as you've described, all of a sudden what happened outside the four walls of your hospital really mattered to your operations and reimbursement. So all of a sudden it was really important for us to have those post-acute care providers and other community-based organizations at the table, so at least we could have communication about how can we all work together because the reimbursement model is changing. And I think we're going to have to lean into some of that moving forward for all the reasons that you described.
Absolutely.
So, we are a large region of hospitals that are represented by HASC. From your seat, from your community, from San Bernardino, the Inland Empire, what role do you think HASC can play in helping to convene and helping hospitals and healthcare providers collaborate to provide service, to continue to provide services to communities during these challenging times?
One word, George, influence. And I think you're on that path now. And you have me bought in, and that's what we're trying to do. It takes more than one voice, one hospital, trying to educate new city council members, new mayors, even people who have been there a while who just don't understand the operations or dynamics of healthcare, to educate them about bills that are coming out, or to convince them to help you place a bill that benefits our hospital or medical industry, from our physicians to, like you said, through the hospitals to skilled nursing. One voice can't do it. It takes collaboration. It takes a leadership organization, and that's why I jumped at the chance to help HASC in any role they wanted me to play, because I see the importance of the strategic plan that you and your department came up with in terms of outreach and political advocacy. And you and I have successes on that already in the last year.
We do.
So we're going to keep up that good work, and we're going to keep up on that path that makes sense.
Well, I appreciate that, and appreciate your leadership along with that of the HASC Executive Committee and Board in leaning into understanding that it is so important for us to develop relationships and maintain relationships at the local level with elected officials on city councils and at the county board of supervisors level. As you know, as we started this conversation with the board, we did an analysis, and over 20% of the current state legislature have started in local offices across the HASC region. So our job, our goal, is to try and develop these relationships, educate individuals early on in their political career, and identify champions for healthcare as they grow those political careers. So really, really appreciate your support. Speaking of politics, last couple of questions for you, John. There's a lot that's happened recently at the federal level. Everything that's happened at the federal level is affecting the state level. The changes that are occurring at the state level are affecting the local level. So my question for you is, how is San Antonio Regional thinking about operationalizing some of these changes? And will it change the way that San Antonio Regional engages decision makers, stakeholders, and the community that you're serving?
I would totally agree with you, George. It's a morass of changes going on. And I think for us, how I keep my team focused, it's about being able to nimbly pivot, right? So as an example, Medicare. Well, San Bernardino, we've used the CHNA to figure out there's 120% growth of seniors in our area, right?
Silver tsunami.
Okay, so we may be losing money because of federal policy related to number of Medicaid patients. We may be losing funding because of sequestration. We may be losing funding soon at the state level, where SB 43 funds should have been given, but they haven't. So you can't count on it unless it's in the proverbial pocket.
That's right.
But what you can do is focus on initiatives that bring a profit, so you can subsidize other initiatives that don't, but the community needs. So I mentioned seniors. We have created a 163,000 square foot center of aging, one-stop shop for seniors.
Wow.
Why are we doing that? Well, first of all, population. Two, it actually leverages the Medicare Advantage payers. If you have a place where their insured want to go. Three, every senior who has to go to an appointment, regardless of provider, if they're wheelchair bound and they don't have a family member who happens to have a vehicle that can take wheelchairs, it's $100 copay even with Medicare, right? I always share my mom as an example. She used to pay $600 a month, so 6 visits a month of different specialties. We are offering that free. we are centralizing scheduling for everybody who's in that center of aging. So the podiatrist could see when the primary care has an opening.
That's fantastic.
They can figure out when the ancillary has an opening, and
Yep.
they can get 3 appointments the same day,
That's fantastic.
right? So our center of aging, which is in Rancho, going to fully open in February, has primary care, geriatrics, podiatry, number of specialties, ophthalmology, optometry, urology, cardiology, dermatology, and then all the ancillaries, including MRI, because this building's huge. And now we're partnering with others to bring in behavioral health and dementia. We have falls clinics in there. It's such a beautiful building. Seniors, they definitely like a destination look.
Yeah.
It's a destination look. We think this is being creative, thinking out of the box, being profitable, and this allows us to open a new maternity ward while people are closing theirs,
Yes.
right?
Yes.
So, yes, we have a new maternity ward opening that'll have its own OBED,
Wow.
private rooms.
Wow.
I don't open a newspaper without seeing a maternity ward closing.
That's right.
We're opening it.
That's right.
And we're able to do it by subsidizing off profitable programs. 2, being very efficient. We're one of the few hospitals who actually break even with Medicare. And then 3, we talked about how the community's wedded to the hospital, not only where they were born, but where they get their care. Can you name another department where you go to a hospital and you leave happy besides maternity?
No.
Who cares if I'm losing a nickel on a dollar?
Right.
They're coming back and they're investing in other services.
Long-term planning.
So to us, it's a no-brainer.
Long-term planning. That's great. That's great. And that model of geriatric care is absolutely phenomenal because, as we all know, the reimbursement for geriatric care generally is very poor, very low. So that's a lot of innovation there, John. A lot of innovation. That's fantastic.
And in our primary care clinics, we're embedding behavioral health specialists in every primary care clinic. And people say, isn't that expensive? Don't you lose money? You've got to think about it. If you have a loved one who has a comorbidity of a mental health issue, they end up being with their physician 40 minutes, 50 minutes. Now, a physician's typically seeing a patient for 20 minutes. They're losing productivity. We're losing revenue. Well, if I bring an LCSW in or another or a psychologist in where they can do a warm handoff, the clinic productivity goes up and it pays for itself.
Yeah, that's great. That's great. That's great. Well, John, I got one last question for you.
Shoot.
And before I ask that question, just want to say thank you so much for taking the time to be in the spotlight. Thank you so much for your support of HASC. And thank you so much for your support in the Inland Empire and beyond. As I mentioned earlier, really looking forward to working with you as our chair. The innovation that you bring to the table, the collaboration that you bring to the table are unmatched. And so, again, just really, really appreciative of your time today.
Thanks, George.
Absolutely. So my question for you, and it's more of a softball for you here, John. If there's anything that you would want to say to decision makers who are struggling and trying to figure out what they can do to help support hospitals in this time of need, in this time of challenge, what would you say to them?
Spend a day in my staff's shoes. Come and learn. I'm coming to you, to your city councils. I only have 15, 20 minutes to tell you what I can tell you.
Very true.
We're doing it quarterly. Come here, learn about the industry because it's needed. And you'll definitely be invested and you'll definitely understand community needs if you did so.
Great. It's a great message. Well, John, again, thank you for your time. Thank you for being here. And also want to thank everyone who tunes into this podcast. This is the first of many. And our job here is to educate, to collaborate, to communicate. This is an opportunity for hospitals in the Southern California region to come together and figure out ways to continue to provide high quality care to patients and communities, because that's the mission. And we do it better when we do it together. So,
thank you for your leadership, George. I definitely see those 3 C's taking shape.
With your joint leadership, absolutely, John. So thanks, everyone. Take care and stay tuned.
Thank you.
In the spotlight.